Welcome, everyone, to our third session of our first day of Kidney Action Week. So happy that all of you have joined us today. Right now, we are about to start our Q&A session with the experts. We have two nephrologists here with us. All the questions that I know that a lot of questions will come in, and we'll try to get to as many as we can. We are here today with two nephrologists. Our first speaker is Dr. Ashte Collins. Dr. Collins is a nephrologist and director of outreach practice with the Division of Kidney Disease and Hypertension at the George Washington University Medical Center. He is an associate professor of medicine at the George Washington School of Medicine and Health Sciences. And in addition, he's the medical director of the Fresenius Lanham Dialysis Center, which is ranked #1 in the Washington, D.C. Capitol Lakes region for quality indicators in patients using home dialysis modalities. He often receives accolades from colleagues and has been nominated for the Washingtonian's Top Doctor list of multiple times. Dr. Collins' research interests include heart disease and chronic kidney disease, health disparities, and patients with kidney disease and outcomes at the end-stage renal disease. Next, we have Dr. Kirk Campbell. Dr. Campbell is professor of medicine and chair of diversity, equity, and inclusion and director of nephrology fellowship program at the Icahn School of Medicine at Mount Sinai in New York. In addition to treating patients with kidney disease, Dr. Campbell leads an NIH-funded research program focused on basic kidney biology and clinical trials in the rare kidney disease space. His work centers on advancing knowledge around underlying mechanisms involved in kidney disease progression while identifying potential targets for therapeutic intervention. He is an elected member of the American Society for Clinical Investigation. He is past president of New York Society of Nephrology and member of the board of directors of the NephCure Foundation, and a standing member of the Pathology Kidney Disease Study Section at the National Institutes of Health, and current president-elect of the National Kidney Foundation. Thank you both for joining us. Really appreciate you being here to answer our audience questions. So for the audience, remember, this session is all about you, and it's all about your questions. So please start typing your questions and comments into the window next to or below the Facebook Live video or in the chat box to the right if you are here with us on the Kidney Action Week website. We will try to answer as many questions as possible. So we're going to have a great discussion. So I'm going to start by asking you, Dr. Collins and Dr. Campbell. So of course, you know, nephrologist is key important person in the entire team if you're on dialysis or living with kidney disease. And nephrologists help at every stage of the kidney journey. Can each of you provide more insight into your role as a nephrologist, as a doctor who specializes in kidneys, you know, as a lead provider of the healthcare team? Can you talk to our audience about what specifically you do that maybe differentiates from maybe a primary care doctor, or if someone has a urologist? Just talk more about your roles. I'll start with you, Dr. Collins.
Sure. So thank you so much for having me. And just to talk about what my day job actually consists of, we are the protectors of the kidney, at least to the degree that we can be. On some level, we play detective. You know, when I'm meeting someone in my office with kidney disease, or they're being told that their kidney numbers are abnormal, part of my duty is to figure out how bad those numbers actually are, what's actually causing that problem, and then figuring out an action plan for what we can do about it. So this chronic kidney disease is a major part of our day job. And of course, we do take care of people who are on dialysis and try to facilitate them getting kidney transplants. But there are many other kidney disorders that we will also pay close attention to, because they can have long-lasting effects. I'll defer to Dr. Campbell to talk about some of the alternative kidney diseases, but I wanted to focus on chronic kidney disease and, of course, what we call end-stage kidney disease, when the kidney function is less than 15% of normal and people either need dialysis or kidney kidney transplant. So we help take care of those patients on top of what the primary care docs might be doing, but with a specific focus on the kidneys themselves.
Thank you, Dr. Collins. And Dr. Campbell, can you talk more about some specific conditions that a nephrologist treats?
Yeah, absolutely. Thanks so much. I definitely agree with Dr. Collins about us playing detective. So we work very closely with our primary care physicians and other multidisciplinary team members in trying to identify the underlying cause of kidney disease when a patient has been diagnosed with having a kidney disorder, whether it's a decreased kidney function or just spilling protein in the urine or there's structural abnormalities with cysts in the kidneys or electrolyte abnormalities with sodium and potassium disorders or genetic conditions, which are becoming more prevalent as we have enhanced our ability to make these diagnoses. We then co-manage patients, right, with our providers. So there's really a spectrum of conditions that nephrologists will co-manage with our colleagues. And as a result, nephrology itself has become a bit more specialized. Dr. Collins touched on a large number of dialysis patients, but of course, there are also patients who are living with a kidney transplant. There are patients who require, management of some of the more rare conditions. There are glomerular diseases that are difficult to diagnose and treat, and specialized centers are often called upon to appropriately manage some of these patients. We have a lot more clinical trials ongoing in this space. So we have a budding group of clinical trialists who spend a lot of their time really developing new treatment options for patients. And we have procedural subspecialties, right? Interventional nephrologists who work to maintain dialysis access and help to ensure that they're patent and working well. And, with a lot of the expertise now expanding across the oncology space, there are onconephrologists and cardionephrologists as well to make the picture even more complex. So I think patients now more than ever have options, right, regarding second opinions, for example, depending on the ultimate diagnosis that they have when managing kidney disease.
Okay, thank you. So, Dr. Collins, I have a question for you. So, what could someone expect a patient on their first visit to a nephrologist?
Sure. So, a lot of it might feel very much like going to see your primary care doctor. We're going to learn as much as we can about your past medical history. And, when we're trying to answer that first question of, why are we even dealing with either abnormal kidney function or protein spilling from the kidneys? We're going to review whatever labs or relevant imaging that is pertinent to the case to try to figure out, exactly what's going on. And then that really helps us with that action plan, whether that is a change in blood pressure management, diabetes management, putting in strategies to best protect the kidneys. A lot of it is more about healthy lifestyle. And, I'd argue so much of it is about what you don't put into your body rather than what you do put into your body. So we focus on which strategies when it comes to diet as well as medication, physical activity that can be employed to best protect the kidneys over the long run. We've learned over the years that kidney disease is largely a disease of aging as well. So we see a certain segment of our patient population is in the geriatric population. So we're trying to get their kidneys to last as long as possible, especially for those who have chosen to have their disease treated conservatively.
Hey, well, we have audience questions coming in right now. Just a reminder to our audience, please type in your questions into the chat box. We will try to get to as many as we can. First question that I have for you, see, I'll pose this to you, Dr. Campbell. I was just diagnosed with stage 4 kidney disease. What can I do to prevent the disease from progressing?
Thanks so much. That's a great question. And of course, it really depends on the underlying cause, right? This is why, as we mentioned earlier, we know that diabetes is the most common cause of chronic kidney disease in the U.S., but there are multiple other causes, right? From hypertensive disease to genetic disorders, to various toxic metabolic infectious etiologies, for example, obstructive disorders, right? Stones, for example, sometimes can cause kidney function to decline over time. So it really depends on the underlying etiology, and that has to be again clearly discussed with the nephrologist and the care management team. Some patients with stage 4 kidney disease benefit from a kidney biopsy, for example, depending on how quickly the kidney function declined and to get to stage 4. Is there a lot of scarring present, for example, is one question that nephrologist might want to factor in. Is there something reversible? To enable the patient to recover some of the kidney function, or is this something more chronic that we really will try to slow the progression of, right, as the questioner posed. And in that case, it's really optimizing blood pressure control. If the underlying cause is diabetes, great blood sugar control is important. And so on, really trying to remove any offending agents that might further put a strain on kidney function, and more and close follow-up, really, right? Because at stage 4, we start to see some of the complications, right, of kidney disease progression, with anemia becoming an issue, or phosphorus buildup in the blood, or other abnormalities that have to be closely monitored and managed. So I think it's a period, whatever the etiology, that close follow-up is needed going forward.
Thank you. And Dr. Collins, a question for you. At what point do nephrologists typically start seeing kidney disease patients, or even maybe more, when should a nephrologist start seeing somebody with kidney disease?
Great question. So thanks so much for that one. I would say across the board, we do these blood tests, and whenever you get either a basic or comprehensive metabolic panel, you most often done in your primary care office, you will see a number on there called the GFR, and that stands for glomerular filtration rate. Shorthand, it's just a way of measuring how efficiently the kidneys are removing waste from the blood. So it's a number that will typically be between 0 and maybe as high as 125. Across the board, if your GFR is less than 30, you should be seen by a nephrologist no matter what. If your GFR is between 30 and 60, we really look at what are the risk factors for that kidney disease progressing. Many of those patients do need to be seen by a nephrologist, but not necessarily all of them. So if you have a GFR between 30 and 60, and there's a lot of protein spilling from the kidneys, if the blood pressure has become more difficult to manage, if we start seeing other complications related to chronic kidney disease, as Dr. Campbell mentioned, anemia, if we start to see an acid buildup in the bloodstream, if we start to see electrolyte abnormalities, those are people who should be getting sent to see us earlier. Any patient with a structural abnormality in the kidney, irrespective of their GFR, should probably be seen by a nephrologist at least once. So people with recurrent kidney stones, even if their GFR is closer to normal, that's someone who should probably be followed by a nephrologist. People with polycystic kidney disease, or if they've had cancer in a kidney and have had to have one kidney removed, even if that other kidney is totally healthy, that's someone who is at risk for chronic kidney disease progression, simply because they only have half of the body's functioning kidney tissue in place. So that rounds out most of the people who should be seeing a nephrologist on a regular basis.
Thank you, Dr. Collins. So, Dr. Campbell, we get this question occasionally. So, we have two kidneys. So, the question that we have from our audience, is it possible to have kidney disease in just one kidney?
Yeah, that's a great question. It certainly can happen. And when you think classically about some of the structural abnormalities that can occur, there are patients who are born, right, with congenital malformations that cause them to only have one functioning kidney, right? There are individuals who may have an obstructing kidney stone on one side, or an issue with blood flow, or reflux, causing injury just to one side. The challenge in many cases is for some of these abnormalities, unless they're pain symptoms or the things that are occurring, they often go undiagnosed, right, and are identified when the kidney function deteriorates, or incidentally on imaging. So it can happen, but the more common conditions, diabetes, hypertension, some of the genetic abnormalities that we mentioned before, they usually happen in both kidneys, right? Cystic disease and so on, polycystic kidneys usually have it affecting, because these are really conditions that are either systemic or are the result of gene mutations that are affecting cells in both kidneys. So it can happen, but it definitely would require further assessment as to why one kidney is affected. And I should just mention as well that there are individuals, just have to highlight this, who do quite well after donating, right, a kidney. Living kidney donorship is something we encourage for those who are healthy. So, for those individuals who are not at high risk for kidney disease, they do quite well donating a kidney.
Okay, thank you. So question, I'll go back to you, Dr. Collins, for this one. A lot of people who have kidney disease also have other conditions. Sometimes they have heart disease, they get up diabetes. How do nephrologists work with other primary care physicians or other physicians that a patient may be working with to make sure that the care is coordinated?
The kidneys are so vitally important in the body because they receive 20% of the body's blood flow every single minute. So, whenever there is disease in another organ, there's a chance that it could directly affect the blood flow to the kidney. We end up, as nephrologists, being our patient's medication safety officers. So, even if someone is being treated for heart disease or cancer or an autoimmune disease, we're the one that's running the safety check to make sure that that medication is being dosed appropriately. So a lot of our collaborative care involves being in direct communication with primary care physicians as well as other specialists to make sure that everyone is on the same page and that that medication is being dosed appropriately. Sometimes we'll even have to give that advice of a certain medication or class of medications being completely ruled out because of the person's chronic kidney disease. For example, a lot of our patients are being seen in primary care or maybe orthopedic surgery for their arthritis. And there's certain levels of kidney function where the non-steroidal anti-inflammatory agents are not recommended. Medicines like Advil, Motrin, ibuprofen, Aleve. So we'll be the ones that are giving that recommendation saying, you probably should not be using those kinds of medications because there's a very close association between use of those medicines and worsening kidney function. So we end up having to be in touch with other specialists and referring physicians quite often in order to optimize patient safety.
Okay, thank you. Dr. Campbell, we have a question from our audience that asks, what are the special considerations for treating somebody who has diabetic kidney disease and heart failure? I guess it's kind of related to the question I had just asked Dr. Collins about coordination of care.
Yeah, but thanks. But it is a great question because there are new classes of medications now that actually show specific efficacy in helping to protect kidney function, being stable, and also protect against heart disease progressing from the morbidity mortality perspective. So agents like SGLT2 inhibitors, mineralocorticoid receptor antagonists. I think there are a lot of commercials on TV for various medications. And so the important thing is to have discussions with your nephrologist, your cardiologist, your primary care doctor about new treatment options that might be out there, right? I think there are several novel agents. The other thing that kidney disease and heart disease will have in common, and diabetes is certainly at the nexus. Diabetes injures the small blood vessels in our body, right? And the blood vessels that supply the kidneys and blood vessels that supply the heart are both affected. There are other vessels that are affected, and the eyes, affecting the circulation. We think about poor wound healing, especially in the feet and other areas. So, a lot of the recommendations to specifically control blood sugar very tightly appropriate diet and exercise, nutrition is really at the center of it all. You end up not just controlling the blood sugar, but also protecting your heart and your kidneys, right? So I think, the organs are intimately intertwined. In fact, patients who have protein spilling kidney disorders are at higher risk for cardiovascular disease, right? And again, that relationship is not extremely well understood, except that there is a very, very direct connection. So, I think, it's certainly something to be aware of, that there are new options available for managing these conditions, but definitely a strong connection between diabetes, heart health and kidney health.
Mhm. Thank you. That's important to know. Dr. Collins, we have a question about the link between high blood pressure and kidney disease. A lot of people don't know that high blood pressure is the second leading cause of chronic kidney disease. Diabetes is number one. Can you explain that link between high blood pressure and kidney disease?
Sure. So going back to what I mentioned earlier, the kidneys require 20% of the body's blood flow every single minute. So the amount of blood that makes it into the kidneys is going to be a critical part of how well the kidneys are able to remove the waste from that blood. When a person has uncontrolled hypertension or elevated blood pressure, the blood vessels throughout most of the body, and especially the ones that lead into the kidney, end up becoming narrow. And that will deprive the kidneys of adequate blood flow. Now, you really don't feel it when it's happening. And I've had this story I probably can cite 100 different times where patients have told me that they, won't even check their blood pressure unless they have a headache. By that time, your blood pressure is probably markedly elevated. But people can go for years with elevated blood pressures and have no symptoms whatsoever. The catch there is the kidney function is very much like the gas tank in a car, where you will feel fine and that car will drive normally, whether the tank is half full or all the way full or even a quarter full. And that's how it works with the kidney function, where you can be at 25% kidney function because of years of uncontrolled high blood pressure and have no symptoms whatsoever. The catch there is once the kidney function is down to a point where you are having symptoms, it's usually irreversible damage that has already taken place. And we have little recourse to actually try to reverse it. So for everyone in the audience who is familiar with hypertension and familiar with kidney disease, if we were to put together a top 10 list of, important things to do to protect your kidneys, irrespective of the cause of the kidney disease, controlling blood pressure would probably be number one as far as general things that you can do to keep the kidneys healthy over the course of your life.
So stay on top of blood pressure and make sure you know your numbers. And another question that we have, it's about polyps. Dr. Campbell, can polyps in the kidneys impact their function?
Yeah, it sort of depends, right? I think there are abnormal sort of growths that you can have in various organs in the body. If there's an external polyp, if you will, it shouldn't really affect the internal function or development or flow of urine. But if there's something obstructing urine flow, that could be an issue, right? Or if there's something like an angiomyolipoma, that can bleed. Those can actually have a big impact on kidney function if there's a significant bleed that has to be addressed, surgically, by removing a portion of the kidney, for example. So it really depends on the location. Is it susceptible to bleeding? So I think there are questions that would have to be answered specifically around the particular growth.
Great, thank you. We have another question, Dr. Collins. I'll ask you, and Dr. Campbell, if you want to add to it, please do. We have a question asking about transitioning from home dialysis to in-center dialysis. Do you have any advice on the best way to transition?
Sure. So when it comes to home dialysis, my vote is if you can be on home dialysis, stay on home dialysis. And I think it's probably underappreciated that there are actually two different kinds of home dialysis. About 90% of all people on home dialysis use what we call peritoneal dialysis, but there also exists home hemodialysis. And if a person has been deemed to be successful in peritoneal dialysis, but they have to stop doing peritoneal dialysis because of repeated infections or some other problem, I would still recommend trying to transition to home hemodialysis prior to going in center. Now, if home hemodialysis is not a realistic possibility and you have to go back in center, remember everything that we do in the world of dialysis involves a trade off. Most people who have decided to do dialysis at home, which for most of our patients involves peritoneal dialysis, they made that decision that they either wanted increased flexibility, increased time to themselves, not being on someone else's schedule. So you have to think about those things that you're giving up when you are transitioning to being in center. So considering the fact that you will now have to be on someone else's schedule because you'll have a set chair time as opposed to starting your treatment when you want to start your treatment. There is one other advantage of in center that I think is relatively underappreciated, and that's the sense of community. You can look forward to, the regulars, the people in the waiting room, the people who are also getting treatment with you, and you'd be seeing them, 3 days per week. And that can sometimes build that community to give you something to look forward to, being able to have someone who can not just understand your condition, but relate to your condition. So we can look at that transition if it has to be made from going from home dialysis to in-center dialysis as a positive if you're looking for that sense of community. And for some people, it certainly provides a sense of extra safety because their treatments are being monitored by someone else and that they're not shouldering the burden all themselves.
Thank you. Dr. Campbell, would you like to add to that? Any advice for somebody transitioning from home to in-center dialysis?
No, I think Dr. Collins covered it quite well. I mean, I think there are a lot of pros and cons to certainly weigh. But I'd also just only add that dialysis, of course, should be viewed as a bridge towards kidney transplant. We hope that the individual's duration on dialysis will not be an extended one. And Dr. Collins covered some of the benefits of home versus in-center extremely well. And I'd just say that the dialysis space is one that's getting a lot of attention because we've not innovated it sufficiently in the last several decades, and there should be some change in the positive direction coming in the years ahead. So I always advise again, talk with your care team. Patients always have options in terms of where the dialysis is done, who the nephrologist is overseeing the dialysis treatment, and just don't forget that, right? If you're not getting the answers that you feel you deserve around your treatment options and your treatment regimen, then you can request another opinion. So just bear that in mind.
Mm, thank you. So we also get a lot of questions about having a kidney transplant, and we have one that asks about age and getting a kidney transplant. Is there such thing as too old to get a transplant? If it is, how old is too old for a kidney transplant?
Great question. Most transplant centers might not necessarily have a firm age cutoff, and it's important to note that each individual transplant center may have their own criteria. So here's the way that I look at it. When it comes to kidney transplants, because they are a limited resource, meaning there are way more people who need kidney transplants than there actually are kidneys available, the transplant community has looked at kidney transplants as wanting to go to the area where it will be of the best use. So they typically will relegate kidney transplants to people in whom their life expectancy would be extended by receiving a transplant. So for most people, between age, from birth up to age about 75 to 80 would likely have their life expectancy increased by getting a transplant compared to staying on dialysis. Most of the transplant centers that I work with directly will typically say by the time you reach age 80, your life expectancy, it will more or less be the exact same whether you get a transplant or stay on dialysis. So they would look at people over age 80 on an individual case by case basis to determine whether, for quality of life reasons or care partner issues, whether it would still be advisable to give that person a transplant. Of course, we have to pay attention to what the actual surgical risks are. So your other health conditions might also determine what your candidacy for kidney transplant is, even if you are younger than 80. I certainly have people in their 50s and 60s who just had cancer the year before, and them having cancer the year before might make their waiting period longer before they can receive a kidney, even though they're not, for lack of a better word, too old to receive a kidney. So every person's individual circumstance needs to be taken into account so that we are providing the most good with the kidney transplant.
Okay, thank you. And Dr. Campbell, we get this question a lot too. Can frequent bladder infections in women lead to kidney disease?
Yeah, I mean, I think that that's also a good question, and it really depends on how severe the bladder infection is and whether or not it leads to any again structural abnormalities like further up the urinary tract or obstruction in any way to urinary flow, which can certainly cause chronic kidney disease over time. And the other thing that can happen, depending on how severe the actual infections are, sometimes some of the antibiotics, right, that are administered can cause injury to the kidneys, right? So, depending, on the duration of administration and the specific antibiotic that's used, some are again broader spectrum than others. Some are by definition stronger, right, at the antibacterial and microbial properties than others. So I think in theory, whether it's direct or indirect, that can happen. And of course, a severe bladder infection can become systemic, leading to sepsis and, a patient requiring intensive care level hospitalization, which can certainly cause multi-organ compromise, including the kidneys. So I think, bladder infections are something that should be taken seriously and treated. And I just recommend, in addition, that if they are frequent, having some, consideration given as to whether or not they're really structural abnormalities that are causing or increasing susceptibility to these recurrent infections that could be intervened on, right? That some patients require procedures to prevent these infections from being recurrent, or medications to maintain an infection-free period.
Thank you. When we first opened, I'd mentioned nephrologists as leading the healthcare team with somebody who has kidney disease. And we also have other members of the team, including a dietitian. So one question that just came in is, from a nephrologist's perspective, when is the best time somebody who has kidney disease should start working with a renal dietitian? Let's see, I'll ask you, Dr. Collins.
Sure. No, that's an excellent question. So it really depends on what restrictions are going to be needed with your diet. There's no such thing as a blanket across the board kidney diet. And if you go too far down the Google rabbit hole when you only have stage 3 or even stage 4 chronic kidney disease, it might lead you to think that there's almost nothing that you actually can eat. And that's simply not the case. When we think about a typical chronic kidney disease diet, there are 4 major factors that come to my mind. Number 1 is restriction of sodium. Number 2, restriction of potassium in certain people. Number 3, restriction of phosphorus in certain people. Number 4, avoiding foods that generate a lot of acid. So we'll, typically give our patients with chronic kidney disease a recommendation to lean more away from animal protein sources, more towards plant-based protein, or what we call a whole food plant-based diet. That will be one of the cornerstones of therapy to try to use nutrition in order to optimize someone's kidney health. So we do a dietary inventory, figure out what a person is currently eating, and then if their optimal diet seems to be deviating very far from what they're typically eating, that's a person who should be seeing a kidney dietitian. By the time most of our patients reach stage 4 chronic kidney disease, they should probably be seeing a kidney dietitian, or at least getting specific dietary recommendations to learn how to best protect their kidneys. Now, when you look at ways to keep the kidneys healthy when it comes to nutrition, the same things that are good for the rest of the body are also good for the kidney. Avoiding processed foods, sugar sweetened sodas, avoiding as much red meat as possible. Some would argue moving all the way towards a plant-based diet and cutting out all animal protein would be best for the kidneys. Now, I understand that for many people that's probably not practical. So working with a dietitian to figure out what the best level is of any type of food might be helpful for that person who isn't ready to adopt a full plant-based diet just yet, but they understand that some changes need to happen in their diet in order to, best preserve their remaining kidney function.
Okay, thank you. So here's a question we have about over-the-counter medications. So we have a question that just came in about Tylenol. Is there anything patients should keep in mind when taking over-the-counter medications like Tylenol? I don't know if that's specifically for someone who already has kidney disease, or if it's something that people who don't have kidney disease should be mindful of.
Yeah, I mean, I think that it's a good. Right. Thanks so much. That's I think patients have to be certainly mindful, right, of over-the-counter medications. And the good thing is that they're pretty well labeled, right, from a warning standpoint of what to look out for. I think Tylenol, acetaminophen, those agents actually are quite safe from a kidney standpoint. We frequently are more concerned about non-steroidal anti-inflammatories like Motrin, Advil, those things, frequently used for pain relief. If patients have decreased kidney function or are at higher risk for decreased kidney function, those agents can actually cause some progressive disease or acute kidney injury, that doesn't always resolve in the shortest turnaround. So I think it's quite important to talk with your physician about the appropriate over-the-counter pain medication to be used. I think Tylenol, even though I mentioned it is safe if patients have liver disease, sometimes there can be restrictions, recommended on how much Tylenol should be taken on a daily basis, because secondarily, liver disease can cause kidney disease. So even though there are things that might not be directly harmful to the kidneys, I think as Dr. Collins said earlier, or organ systems are heavily interconnected, right? And they work very closely to maintain overall, health, right? So it's important, again, to be conscious of your own medical history and what specific medications might be safe or unsafe in any particular condition.
Thank you. Dr. Collins, another question. What are some genetic causes of kidney disease, like PKD, polycystic kidney disease?
Sure. And so that is probably one of the most common, if not the most common, genetic kidney disorder that actually leads to kidney disease in adults. And this is a condition that can be passed down from your parents. It only takes one parent to give it to you if they have an affected gene, and it actually causes cysts to grow throughout the kidney, and over the years, it can actually displace the normal functioning kidney tissue and put people in a position where by the time they're in their 50s or 60s, they're potentially needing dialysis and or a kidney transplant. So that's one of the most common ones. Many of them can actually affect people while they're in infancy. So there are a couple of tumors, such as Wilms tumor, where cancerous tumor forms inside of the kidney, usually in infants, and it's typically treated by having the entire kidney removed. So then we end up finding that this congenital or genetic disease required a kidney to be removed when a child is 2 or 3 years of age, and then they end up living their entire life with just one kidney. There are other types of diseases that can be genetic in nature that will affect the kidney's ability to either hold on to or get rid of certain electrolytes. And those conditions can make people be chronically dehydrated, or what we call volume depleted. And that can also cause what we call acute kidney injury, where the kidney function declines quickly over a matter of hours to days.
Okay, thank you. Another question that we have coming in is about hyperkalemia, which is very common in people who have kidney disease. So, Dr. Campbell, the question is it possible to have chronic kidney disease, hyperkalemia, but not have diabetes or high blood pressure?
Yeah, the answer is yes. I think one of the functions, right, of the kidneys for us to maintain appropriate electrolyte balance. The kidneys serve a variety of different roles, regulating blood pressure, maintaining your hemoglobin level, but also helping to maintain a normal potassium level, right? The kidneys excrete potassium, and when patients have advanced kidney disease, even if they don't have hypertension or diabetes, oftentimes, there is more potassium retention, right? And this is something that can be quite dangerous if the kidney function has severely decreased. This is one of the actual main indications for emergent dialysis. If patients have very advanced kidney disease, it's one of the indications where we need to start it right away. Fortunately, there are medications that we have available that can lower the potassium level, but potassium is an essential electrolyte in our body, and our intracellular stores are very high, and potassium can leak right back out. So this is why either maintenance dialysis or kidney transplant are really often indicated, right, to maintain normal homeostasis with respect to electrolytes. But that is a great question. And one of the reasons nephrologists frequently check labs to make sure potassium levels, acid base status, and other lab abnormalities are closely monitored.
Okay, thank you, Dr. Campbell. Dr. Collins, we have a question about nephrotic syndrome. What is nephrotic syndrome, and is it a condition that can improve?
So nephrotic syndrome is kind of it's a couple of things. Number one, a large amount of protein spilling from the kidneys. We measure the protein spillage in either milligrams or grams. So typically greater than 3,500 milligrams of protein spilling from the kidneys per day. We would typically see it associated with a low level of protein that's left behind in the blood because so much of it is leaving via the kidneys. And typically these people will have a lot of swelling in their legs because when the kidneys are losing lots of protein and they can't clot back in, they will retain the one thing that they can still do, which is sodium. So then the kidneys will hold on to sodium, water follows the sodium, and then the legs become swollen. So there are a host of conditions that can cause nephrotic syndrome. Most of these can only be diagnosed by doing a kidney biopsy. And because most of those conditions are inflammatory in nature, the medications that we typically use to treat the various kinds of nephrotic syndrome are going to be directed at the immune system. So powerful anti-inflammatories that in the best cases can completely reverse the course of the nephrotic syndrome. And I have seen my share of people who have become completely cured. The word that we use is remission, meaning that there's no longer large amounts of protein spilling. So it certainly can be treated.
Okay, thank you. So we have another question about genetics and kidney disease. Dr. Campbell, how can someone find out if they're genetically predisposed to different types of kidney disease? What can they do?
It's a great question. I think that we've seen some estimates that among all comers with chronic kidney disease, about 10% of patients actually have a single gene mutation that's responsible for the kidney disease. And that's not including disease modifiers like, apolipoprotein L1 or ApoL1 that's been widely described among patients with the protein spilling disorders like FSGS. Maybe 20 to 30% of patients have a disease-causing mutation that's really the culprit, right, in developing this condition. So, genetic testing, which traditionally was not widely available in the kidney space, has become a lot more available in the last 2 to 3 years. And so it's really a conversation with the nephrologist and sometimes a primary provider. There are patients who are doing genetic testing panels that are available right on the over-the-counter market as well, and coming in with the results. I'm not sure we generally recommend that as a part of a medical screen, but that's available. So I think being aware of the family history is one step. I think certainly if there's a close family member or family members with kidney disease, there are various institutions and commercial providers who will do testing on family members, often at a significantly reduced cost. So it's really just a matter of talking about these things, and we'll certainly get to some recommendations later on. Being aware of your kidney function, being aware of the family history of kidney disease where it may exist, and talking to the providers about the benefits of doing genetic testing would be essential steps to take.
Okay, we have another question about primary care physician and coordination here. So the question is, can a primary care physician refer someone to a nephrologist? And at what point should a primary care physician notify a patient of declining kidney function? That's
Great question. Yep, and honestly, there are more patients with chronic kidney disease than there are available nephrology appointments to take care of all of them. So your primary care provider is still going to be a very important piece of trying to treat and prevent chronic kidney disease. I had mentioned those kind of categories of people who should absolutely be seen by a nephrologist. Folks with GFR less than 30, people with GFRs less than 60, and they're at risk of progression, particularly with high blood pressure or lots of protein spilling from the kidneys. And then even people who have GFRs greater than 60, if their kidneys are spilling a large amount of protein, then those people should probably be referred to us as well from their primary care providers, because they're already going to be deemed at higher risk of kidney disease progression, even if their GFR is listed as normal at the time that the lab was done.
Okay, thank you. So we have another question about the transplant process. So the question is, could you talk a little bit about what the process is for finding a living kidney donor? And the question also related to that is, how long is the process for a hospital to conduct the screening for a living donor?
That's for me, I guess. Yeah. So I would say it's a great question because again, as we mentioned, kidney transplant is the best option for advanced kidney disease, and again, dialysis should be viewed as a bridge to transplant, and living kidney donor transplants are also more optimal than deceased donor, right, kidneys, right, in terms of the overall organ survival. and length of duration that the organ would be functioning optimally. Patients are often initially asked about known donors, and a misconception is that a donor has to be a relative, which that's not the case. I think there are also great peer donation chains at institutions around the country where individuals who may identify an appropriate donor who isn't necessarily the best match for them. The best match for that donor could be identified through that peer donation pool. So it, again, requires connecting with a transplant center. The primary nephrologist would refer the patient to the transplant center, and that's where the initial screening and workup would be done. There's a question earlier on age cutoffs. Patients who are undergoing kidney transplants have to be cleared and deemed appropriate candidates for the transplantation surgery, and there are various cardiovascular screens that have to happen, an extensive checklist to make sure the patients are appropriate for the procedure. And then a similar process is undertaken for any potential donors, right? And of course, the transplant centers will undertake the process of matching the donor with the recipient. It can take, of course, it depends on the individual circumstances, but that extensive medical, psychological, social work checklist has to be exhaustive and maintained, right, at regular intervals to ensure the health, right, of the donor as well as the recipient. So it's variable, and a lot of it depends, and there are barriers, right, to completing this clearance process. Folks are busy with work and school and other commitments. So again, that's a part of the reason that wait list times can be long, and the wait time for kidneys can be longer. But again, it really depends on individual circumstances.
Can I
Thank you
piggyback
for
on
that.
that?
Oh, please go right ahead.
Yeah. So Dr. Campbell had mentioned, part of that screening process. And I think before anyone starts looking at how I can find a living kidney donor, they first have to be very aggressive about making sure that they are themselves healthy enough to receive a kidney. Dr. Campbell mentioned, making sure that you're screened for cardiovascular disease. We also have to do what we call age-appropriate cancer screening. After those two, we do a test of major infectious diseases, because when someone receives a kidney, you're going to be receiving medication that'll suppress your immune system. So you can't have untreated HIV or tuberculosis. There's a host of other viral infections that gets tested for. And then the fourth category involves kind of a psychosocial assessment, making sure that you have a stable home, that your finances are stable, that you have the insurance coverage, and that is still a thing in this country, that many of our patients require two different insurances, usually either Medicaid, Medicare, plus commercial insurance in order to be listed for a kidney, because they want to guarantee that the medications will be paid for after the fact. After those four check boxes are checked, then it's time to get your potential living donor screened to see if he or she is healthy enough for a kidney. Just a word to our audience: once you put that out there, and that you have a person, a friend, a family member who agrees to present themselves for evaluation, you cannot get into all of their business. So you can't ask them, so what's going on at the transplant center? Like, did they say that you're good to go, that you can donate to me? Because that person's health issues are still their business. So, it would have to be their prerogative to share with you where they are in the process. It usually takes a couple of months. Most of the transplant centers that I work with will give an individual maybe up to about 90 days to get that workup done, to check those four check boxes.
Okay, thank you. And just for the audience, please check the agenda for the rest of the sessions for Kidney Action Week, because we do have some that focus more on finding a living donor and the transplant team. And also, please check our website, because kidneyfund.org, we just have a lot of different topics that we cover, so you could probably find some information there too. Let's see. So Dr. Campbell, we have a question about... So I just lost it for 1 second. Yes, it's about having a displaced kidney. Can you talk about what a displaced kidney is and if it's a serious condition?
Yeah, I mean,
Sure.
I think,
Sorry,
go
go
ahead,
ahead.
Dr. Collins. Go ahead. No, go ahead. Go ahead.
Well, I'm assuming that's referring to someone who had a congenital condition where the kidney either didn't fully separate from the other kidney, or whether it is lower or higher where it's supposed to be. For many people, it doesn't cause them any problems whatsoever, and it just gets discovered incidentally when they end up getting their abdomen imaged for some other problem. But in some people, it can lead to the urine not draining from the kidney appropriately, which can increase the risk of kidney stones and kidney infections. And as you get more infections directly in the kidney, that can sometimes cause scarring and potential loss of kidney function. So if you know that you have a displaced kidney, that's someone who falls under our category of having a structural abnormality and should be seen by a nephrologist regularly.
Okay, thank you. So we had a couple of questions from our audience about spilling protein in the urine. Can you reduce the amount of protein that's spilling in the urine if you have that? And let's see, our last question, I think we'd be able to take two, is can you explain the BUN on a lab report and how do you reduce ferritin? So let's see, I'll ask the question about spilling protein to you, Dr. Campbell. Can you reduce the amount of protein that you're spilling?
Yes, you definitely can. And it really want to, of course, define what's causing the protein to be spilled in the urine. It can be from a variety of causes. We mentioned some genetic etiologies. It could be due to diabetes or hypertensive disease. Some patients have very little. There's a question earlier about nephrotic syndrome. Nephrotic range proteinuria is more than 3 or 3.5 grams of protein in the urine. So, it really depends on the underlying etiology, and sometimes patients require immunosuppressive treatment. Sometimes classes of blood pressure medication can reduce the protein in the urine, and there are new classes of agents now that specifically on their FDA label indication have been shown in clinical trials and among patients who have been prescribed to decrease the amount of protein in the urine. And protein is really a sign of kidney injury, right? It's a sign that the kidneys are being strained. So we do want to see proteinuria reduced from a variety of different interventions and monitored closely in conjunction with close nephrology follow-up.
Okay, thank you. Dr. Collins, would you like to add anything to that about spilling protein in urine?
But blood pressure control, that's still going to be essential, irrespective of what is actually causing the protein spillage. Get that blood pressure down, you'll affect the actual flow of blood through the microscopic kidney filters, and that can help reduce the protein as well.
Okay, thank you. So I'll just ask, maybe our last, if you could both take 30 seconds, if there's any one thing as a nephrologist that you would like to share with our audience that you think is really important for them to know from the perspective of a nephrologist, what would it be? I'll start with you, Dr. Campbell.
Yeah, thanks so much for, again, a great job moderating this session and for the great questions from the audience. I would say, it's important to note that nephrologist is an essential part of the multidisciplinary care team. I think there are some very good questions about connecting with nutritionists, the role of the primary care physician. I think patients and their, care providers and partners play an essential role in enhancing communication, right, among all team members. And nephrologists, like all other physicians, the more information we have about how patients are doing outside the office and, what medications are being taken, prescribed and over the counter, what challenges there are, and barriers to care, the better we can respond and appropriately manage some of these conditions. So, I think just always have an open line of communication and just kind of view us as an essential part of that care team.
Thank you. And Dr. Collins, just maybe 30 seconds or so,
Sure.
what's the one thing that you would like people to know from your perspective as a nephrologist that you think is really important?
Sure. Well, I touched earlier on this idea that the things that are good for your overall health are likely going to be good for your kidney health. So, if I mention a very quick top 10 list of things that you can do, I mentioned blood pressure control early. I mentioned avoiding the sugar sweetened sodas, avoiding lots of processed food, getting 2.5 hours of exercise every week, making the primary fluid that you bring into your body water. If you smoke, stop smoking. If you don't smoke, great, don't start. Hopefully none of those, factors were news to any of you. And you might see someone trying to sell you some sort of kidney supplement. Most of what they're trying to do is separate you from your money. Because once again, keeping the kidneys healthy is more about what you don't put into your body rather than what you do put into your body.
Well, thank you so much. And I want to thank you both, Dr. Collins, Dr. Campbell, for spending this time with us and answering live audience questions. We always get a lot of questions from our audience, and to have the opportunity to ask directly to nephrologists, it's just much appreciated. And we hope that we'll be able to have you on again, Kidney Action Week, or even a live webinar session when we have those in the future. I just want to remind our audience that coming up, we call our mini sessions. It's about maintaining a nutritious lifestyle when you're living with kidney disease. That starts at 6:35 p.m. Eastern Time. And coming up at 7 o'clock, we have a live session about the importance of understanding the cause of your kidney disease. So we hope to see you there. If you aren't already, please follow us on Facebook and check your email from information from kidneyfund.org. So we hope you join us also for the rest of Kidney Action Week. Thank you.